Welcome to our video on urinary tract obstructions. Let's begin. These are the topics we'll be discussing for urinary tract obstructions. Let's start by describing the general characteristics. Urinary tract obstructions are more common in men due to the fact that they have a prostate and are able to develop diseases such as benign prostatic hyperplasia and prostate cancer. A urinary tract obstruction does not usually cause acute kidney injury unless the obstruction is bilateral or there is pre-existing renal damage. When it comes to classification, urinary tract obstructions can be subdivided into multiple categories: acute versus chronic, lower versus upper tract, unilateral versus bilateral, or complete obstruction versus partial obstruction. Let me just make some clarifications using an image. In acute obstruction, the clinical features are sudden in onset compared to chronic obstruction, which causes progressive renal failure or uremia, recurrent infections, and bladder calculi. A lower tract obstruction is found below ureterovesical junction, meaning below where the ureter and bladder meet, which is here, and affects urination, whereas an upper tract obstruction is found above ureterovesical junction and typically causes renal colic. Then you can determine if it's complete versus partial obstruction. And finally, when it comes to upper tract obstructions, so ureter and up, you determine whether it's unilateral or bilateral. The degree of damage to kidneys and likelihood of return to normal renal function is dependent on severity and duration of obstruction. Let's move on with etiology. Etiologies can vary depending on whether it's the lower tract or upper tract that is obstructed. Lower tract obstructions can be caused by benign prostatic hyperplasia, prostate cancer, urethral strictures, renal stones, neurogenic bladder syndrome, bladder cancer, and trauma. Neurogenic bladder syndrome is a lack of bladder control due to a brain, spinal cord, or nerve problem. It can be caused by diseases such as multiple sclerosis or diabetes mellitus. Trauma can be from a pelvic fracture or straddle injury. As for the upper tract obstruction, etiologies are subclassified into intrinsic and extrinsic causes. Intrinsic etiologies include kidney stones, blood clots, sloughed papilla, seen in renal papillary necrosis, crystal deposition, tumors, strictures, and ureteropelvic and ureterovesicular junction dysfunction. As for extrinsic etiologies, these include pregnancy, gynecologic or metastatic tumors, abdominal aortic aneurysms, retroperitoneal fibrosis, endometriosis, pelvic organ prolapse, hematomas, Crohn's disease, and diverticulitis. As you go through all the lectures, you will be able to connect diseases and causes and how they relate with one another. Let's move on to clinical features of obstructions. The clinical features depend on duration, location, and etiology of obstruction. Renal colic and pain is more common with acute obstruction caused by kidney stones, sloughed papilla, or a blood clot. While pain may be present, it may only manifest during urination. Chronic obstruction is more typically asymptomatic. In a lower urinary tract obstruction, the patient may present with suprapubic pain and distension. Urine output may be normal, though oliguria or anuria may be seen in complete obstruction, usually in lower tract obstruction. There are signs and symptoms of urinary tract infection like costovertebral pain, fever, and pain with urination, which can be a result of urinary stasis or stones. Hypertension may be seen in oliguric patients due to sodium and fluid retention. And lastly, renal failure due to the stone blocking the urine flow, leading to insufficiency and hydronephrosis, dilating the renal pelvis and calyces. Let's move on to how the diagnosis of a urinary tract obstruction is made. When it comes to diagnosing, a renal ultrasound is the best initial test as it shows urinary tract dilation, as it is very sensitive and specific for identifying hydronephrosis. A urinalysis may reveal hematuria or proteinuria, and also can show signs of urinary tract infections such as pyuria or bacteriuria. Standard laboratory tests like complete blood count, electrolyte panel, blood urea nitrogen, and creatinine should be drawn to help further narrow down the etiology of obstruction and assess renal function. A kidney, ureter, and bladder X-ray, also known as KUB X-ray, can reveal stones if they are radio-opaque. There are multiple tests that can be done to identify the site of obstruction, and they have different indications based on suspected area of obstruction and patient presentation. An intravenous pyelogram, also called IVP, is used before making surgical interventions and uses intravenous contrast to identify the obstruction site. The contrast material does have some contraindications such as pregnancy, allergies, and renal failure. If it is suspected that the patient has a lower tract obstruction, then a voiding cystourethropy can be done, or a cystoscopy is done to evaluate urethra and bladder. And finally, a CT scan can also help identify the cause of obstruction, particularly stones. A non-contrast CT scan is the best test of choice for confirming nephrolithiasis. This is a renal ultrasound image showing hydronephrosis. Notice the widened renal pelvis. This specific patient had a uretero-pelvic junction obstruction right here. A 37-year-old woman with a history of endometriosis presents to the emergency department after she developed dysuria, left flank pain, nausea, vomiting, and generalized weakness. Initial lab eval is notable for normal CBC, BUN of 27, and creatinine of 2.57. Abdominal ultrasound reveals bilateral hydronephrosis. If left untreated, this patient is most likely to develop what complication? The findings on abdominal ultrasound are consistent with an obstruction in the lower urinary system leading to bilateral hydronephrosis. In this particular case, this patient's endometriosis likely invaded the urinary system and caused an obstruction. The Stark elevation and renal function test suggests considerable kidney injury already. Hence, if the obstruction is not alleviated promptly, this patient may suffer permanent renal failure. And now to end the lecture, let's discuss the treatment. The treatment depends on duration, severity, location, and etiology of the obstruction. For a lower urinary tract obstruction, a urinary catheter is used for acute obstruction as it can be both diagnostic and therapeutic. A urethral catheter is the first choice, but if passage is difficult or contraindicated, then a suprapubic catheter may be used. If it is determined the cause of the obstruction is urethral strictures, then dilatation or internal urethrotomy is indicated. If the patient is diagnosed with benign prostatic hyperplasia that has resulted in an obstruction, then a prostatectomy is indicated. For an upper urinary tract obstruction, a nephrostomy tube is used for acute obstruction to allow for drainage. Use of a nephrostomy tube is particularly important in the urgent setting when kidney function is impaired or infection is present and source control is needed. Finally, a ureteral stent may be placed through a cystoscope if there is ureteral obstruction. Treatment is also dependent on duration and severity of obstruction. In an acute, complete obstruction, pain or renal failure may be present. This requires immediate therapy, meaning a rapid hydration, a urinary catheter, since it can be both therapeutic and diagnostic, and possibly surgery to remove the cause of the obstruction. An acute partial obstruction is usually due to stone, so the treatment will be similar as a complete obstruction, as discussed in our lecture on nephrolithiasis, diagnosis and management. These measures include pain control, hydration, tamsulosin, and antibiotics. Chronic partial obstruction requires immediate therapy only when infection, severe symptoms, renal failure, or urinary retention is present. A 55-year-old woman presents to the ER reporting bilateral flank pain and no urine output for 3 days. She has past medical history of cervical cancer detected by Pap smear 3 years ago. Her vital signs include temperature of 37 degrees Celsius, blood pressure of 155/90, heart rate of 88, and respiratory rate of 15. Lab findings are significant for BUN of 40, creatinine of 4.5. The physical exam is unremarkable. What is the best initial diagnostic test for this patient's current complaint? A. Renal ultrasound. B. HPV testing, C. Abdominal MRI, or D. Pap smear. This patient presents with bilateral flank pain and no urine output for 3 days. These findings suggest anuric acute kidney injury. She has a past medical history of cervical cancer detected by Pap smear 3 years ago. Therefore, it is likely that the cervical cancer metastasized and obstructed ureters, inducing hydronephrosis and anuria. Acute kidney injury is further supported by a BUN of 40 and creatinine of 4.5. The best initial diagnostic test for urinary tract obstruction and hydronephrosis is renal ultrasound. This is because the ultrasound is very sensitive, specific, non-invasive, and cheap. Therefore, the correct answer is option A. Here's a slide reminding us of the diagnostic test for urinary tract obstruction. And this is a renal ultrasound image showing hydronephrosis. Please note the widened renal pelvis. Let's discuss why other options are incorrect. Option B, HPV testing, is incorrect because although it can be used in diagnostic workup of cervical cancer, the workup for acute urinary obstruction is the priority in this patient. Option C, abdominal MRI, is incorrect because although it can rarely reveal the source of urinary tract obstruction, it's more expensive and time-consuming than renal ultrasound and typically not part of the initial workup. Finally, option D, Pap smear, is incorrect. Although Pap smear can be used in the diagnostic workup of cervical cancer, at this point we need to urgently address the acute urinary obstruction as it can result in rapid deterioration of the patient. And that concludes our lecture on urinary tract obstructions.